Don't be focused on just diagnosis and just one problem in your patients. Comorbidity is a rule rather than exception.
Krka Talks podcast, where we share knowledge and personal thoughts with healthcare professionals and the general public.
Hello and welcome to yet another Krka Talk. My name is Ante Silić. I'm a psychiatrist from Zagreb, University Hospital Sestra Milosrdnice. And I am proud to announce and host Professor Milan Latas, my dear colleague and friend who I've known for years now, who I admired his writing skills, his editorial skills, his publishing skills. And today, primarily, we will be talking about depression, about anxiety, about comorbidities. I think it's a rather important subject because we are kind of drilled through classification systems to think in terms of one diagnosis per patient. So what would you say about these comorbidities in the anxiety and depression?
First of all, dear Professor, dear Ante, thank you for those words that you said to me. Comorbidity could be a huge problem in psychiatric practice because it's very often that we focus only on one disorder or one problem that a patient could talk about us and which bothers him the most. But the problem is that some patients don't have only one disease or only one disorder. They usually have more than one disorder. That could be the problem in diagnostic problem, as in diagnostic view, but also in therapeutic view. If we don't ask patients about presence of some other problems or diagnostic problems, we could not give him a good therapy, and we will not get him very better that he used to want to be.
Mm-hmm. Exactly. That's the issue that most of psychiatrists, or probably in the other branches of medicine, but we are not anything other than psychiatrists. Basically, the DSM system or ICD system was only at one point, as far as I know, included the axis system, which allowed us to code and include comorbidities in a more logical way. Now we are still deciding for the one, and of course we are not. Nobody forbids us to write more, but still, how often would you say anxiety coexists and is comorbid to depression, and vice versa? And what would be the best therapeutic approach to a person suffering both from depression and anxiety?
Well, previous research studies said that the comorbidities are rather rule than exception, that most of patients with depression or anxiety disorders also have two or more psychiatric disorders, but also have comorbidities with somatic disorders or diseases. We have done the research study of Cosmos that was international epidemiological study that includes patients from Croatia, Bosnia and Herzegovina, Macedonia, and Serbia. More than 2,000 patients, we can put it in a sample and research their diagnosis. And we are asking them about comorbid conditions that occurred almost the same time as indexed disorder with primary disorder. And the problem is that more than half of patients with depression also have some other diagnosis. Most of all, that was anxiety disorders, especially generalized anxiety disorder, but also they have some somatic problems like circulatory diseases, like endocrinologist diseases. And almost the same situation was in a sample of anxiety disorder patients. Most of them also have depression. About half of them had the depression. That could be the problem if the anxiety disorder take a long time to patient to get treated, to get better, and depression came as a result of anxiety disorder. Also, patients with anxiety disorder, mostly with generalized anxiety disorder or panic disorder, have some other somatic diseases as occurrence disorders with psychiatric problems.
Yeah, the Cosmos is actually the first study that at least I'm aware of, that kind of links to the Scandinavian register studies, and that actually showed us sobering results about what do the comorbidities mean in terms of shorter life expectancy for our patients. Primarily, they were doing the first published results from Scandinavian register studies were those covering the increased mortality in schizophrenia patients. So this probably, at least I think so, the inspiration for Cosmos that you've done through the multi-regional study. And do you have any maybe unpublished data about the therapy, or how did the therapeutic approach in Cosmos came out in the results?
So we have wrote a paper and we have done it for reviewing. It's actually in reviewing processes. And those data indicate that as we expected, that antidepressants was the first line in patients who were treated from depression, and also the patients who were treated with anxiety disorders. Also, they have some anxiolytics, benzodiazepines. Some of them get antipsychotics. But we are talking about antidepressants. The SSRIs are the first line treatment, and they are present at the most frequent use. And when we are talking about SSRIs, the escitalopram was the main medication that was used in patients with depression, but also in patients with anxiety disorder. The second line was sertraline. The difference between depression patients was not so huge, 29 versus 27%, but in anxiety disorder, escitalopram was this discrepancy was much more present, and escitalopram was maybe present for 1/3 of patients, and the other antidepressants was present for much lesser number of patients.
Mm-hmm. That's why I gave you the introduction I gave you, because your papers actually correlate with my practice, with my everyday clinical practice, because we often find ourselves reading a paper that suggests this and that, and then you don't relate to it
to clinical practice.
To a clinical practice in
to
any level. But
yes.
This one actually
yes, that
does.
was epidemiological studies from 4 countries, 2,000 patients, and we have done research about on the field. What do psychiatrists or neuropsychiatrists really do with those patients? And that was the result of the study.
Maybe from your clinical practice for a patient that has comorbidity of depression and anxiety disorder, what would be your most prescribed dose of escitalopram? Would it be 10? Would it be 5? Would it be 20?
Well, it depends on the patient and his clinical presentation. He's more depressed or more anxious. The dosage have to be 15 or 20 milligrams. No, far from 20 milligrams. For sertraline, it was 100, maybe 200 milligrams per day. And some patients have to get benzodiazepines, of course, in the first days or weeks of a treatment to get better, and after that we cut it.
What was your experience with within the study or out of it in the clinical practice with pregabalin for anxiety disorders in comorbidity with major depression?
Well, pregabalin is not indicated for patients with major depression. It could lead down the symptoms of anxiety in patients with depression, but it is not first line for patients with depression. But also we can give patients with generalized anxiety disorder. Pregabalin is the first line of treatment. The dosage is about 150 starting dose to 300 or 450 milligrams per day for those patients 2 times a day, or in the morning and in the evening.
So to profit more for your past clinical and publishing experience, how long do you wait before raising dose, before changing drug or molecule? For example, you start with 10 milligrams of escitalopram.
I usually start with 5 milligrams. When we are talking about escitalopram, I usually start with 5 milligrams for 6 days. And after that, I raised it to every patient to 10 milligrams. And I saw him about 10 days after the initial treatment, and just looking about side effects. First of all, does he have side effects from the therapy? And after 2, 3, maybe 4 weeks, I checked about clinical pictures about improvement. So if he does have improvement, I don't change the dosage. If he does small improvement, I actually get more dosage for 15, or I get 20 in the start from 10 to 20 milligrams. But if you don't have any improvement, I switch to another medication.
So if you had to wrap up and make a couple of conclusions from today's talk, what would those be? What would be the major points that you would like
Major points from my clinical view and the results from Cosmos study is that comorbidity or co-occurrence of disorders could be a large problem, huge problem first of all for the patients, after that for us, for psychiatrists or neuropsychiatrists, because if we don't look at the broader pictures, if we just focus for one disorder, we could not get proper diagnosis, and after that we don't have a proper treatment for that patient.
And regarding the Cosmos also, that actually
Yes.
covered
Yes.
the same story.
Yes. The results are on the line of clinical practice.
As we concluded earlier. Perfect. Thank you very much. And now just, I have another question for you, if you don't mind. How do you balance all these obstacles that are in front of you in your professional part of life with those in private life? How do you, this job can be overwhelming sometimes.
Yes.
How do you manage?
Sometimes,
What do you do? What's your
every
secret?
Well, I have 2 secrets. I train a lot. I train a triathlon for swimming, running, and bicycle. And the other point of view is that I like to get my friends out of psychiatry and to get them every day to make an appointment to get on a walk or maybe a training or go to some drink, coffee, and something like that.
Thank you very much. Very good advices. 2 of them, at least. So thank you for this interview, for sharing your knowledge. And thank you for following this episode of Krka Talks, and hope to see you on the next one.
Krka, because we stand by you for health, knowledge, and motivation.